Hello, everybody, and welcome to our second webinar of the year 2020 in our Global Green and Healthy Hospital webinar series. My name is Lukman Yusuf. I'm Regional Coordinator for the Global Green and Healthy Hospital Initiative in Africa, and I'll be your host for this webinar series. Following the release of the Healthcare Without Harm fact sheet on managing COVID-19 waste in healthcare settings, we had a series of questions that kept coming in, and we decided to host a series of webinars to address some of these issues. I'm pleased to have three presenters who I've worked with in the past, and I'm still working with them. Some of them have very, very good network base within South Africa and Africa. I'm pleased to have Dr. Richard Amfu from Ghana, Ms. Dimakatso Ndlapo, and Rudo Samudzi with us today. They will be sharing with us some of the very important information that with regards to healthcare waste management in the healthcare settings. Please note that this webinar is recorded, and we'll be sharing the link to the recorded version of the webinar. We would have three presentations running concurrently, and we would also be taking in questions. So if you do have questions, please put your questions in the chat box on your right-hand side. To start this webinar, I'm just going to give a brief overview of GGHH. So some of you are familiar with GGHH as members, and but for those who aren't, GGHH is a network of health institutions, hospitals, healthcare facilities, health systems, all working towards reducing their environmental footprint. So it's a program for healthcare without harm, and it was launched in Africa in 2013. And the network has been running for about 7 years now. We have formed a very, very powerful and a really expansive network of health systems, health organizations, and hospitals, all working as a collective to reduce their environmental footprint and move sustainable healthcare forward. So the map in front of you is our global map, and it shows the number of members from across the continent. Our members are pretty diverse geographically. Currently, we have over 1,320 members in 68 countries across the world. They are all representing the interest of 43,595 hospitals and healthcare centers. So in addition to these hospitals and facilities, we have larger healthcare systems and multiple hospitals and healthcare facilities in each region. And as I mentioned before, Healthcare Without Harm runs the Global Green and Healthy Hospital network and has regional offices in the US, Argentina, Belgium, and Asia. But in addition to this office, Healthcare Without Harm also has regional partners that it works with at both national and regional level. Some of you are familiar with Groundwork in South Africa, which is an environmental justice organization. And Groundwork facilitates the Global Green and Healthy Hospital initiative within the Africa region. We also have they also have strategic partners in Australia, China, India, Brazil, and Nepal, who deliver the GHH program in their own region. So I think recently we had one of the very good landmark. We had 98 members in Africa representing the interest of over 6,000 hospitals and healthcare centers. And this map just shows you the members from different parts of the world. I mean, from Africa especially, we have 8 countries that are all participating in the Global Green and Healthy Hospital. Cameroon, Ghana, Kenya, Madagascar, Morocco, South Africa, Tanzania, and Zambia. The GGHH agenda is based on a 10-goal framework, and it really serves as a foundation for the network. This 10-goal framework allows hospitals to take into account the impacts of their activities on the environment and health, and it ranges from leadership up until purchasing. So it looks at issues on chemicals, what kind of chemicals hospitals are procuring, what um, what are the impacts of these chemicals on the environment, and in fact, it looks at a lot of all of these factors, goes on to waste, what kind of waste is being generated, where is this waste disposed of, who are the people that are impacted, and how do you reduce your waste right from when things are being procured in the hospital, because we understand that after paying of salaries in hospitals, procurement of materials also contributes to a large budget sheet for the hospital. So it looks at all of those things, right from procurement up until the point of disposal. So we know that healthcare facilities can have a negative impact. Some of these activities can have negative impacts on the environment and health. But we also recognize that some of these activities as well present opportunities for hospitals to identify their impacts and also reduce their environmental footprint. So, what are the opportunities for improvement in healthcare facilities? These are the areas that we do focus on in this global green and healthy hospital agenda. So, the Green and Healthy Hospital initiative also has developed tools and resources to assist members to reduce their environmental footprint and promote environmental health. Some of these tools and resources are all available online. Some of them you can only access them once you become a member of the network. But these resources, for example, are like guidance documents on waste, on water, on energy, on procurement. And this guidance document provides guidance basically to hospitals to be able to take their baseline assessment, identify areas for change, and takes measurable steps towards addressing some of those impacts that they do have. So all these guidance documents are all available online, and they are free for you to access. We also have an internet platform called GGHH Connect, and this allows members to be able to connect with likewise individuals like themselves, ask questions, share what they've learned, and also seek resource materials as well. So it allows members to have access to also experts in the field, and have access to whatever resources these members will be able to share, and these experts are also able to share on this platform. So it's a platform for connection basically for members. So we do have, this is exactly how we have envisaged that hospitals can begin to change and begin to move their facilities forward towards a more sustainable future. So the first thing that we do identify is that hospitals have to first reduce their environmental impact. They need to decarbonize as a hospital the operations right from the point of procurement, like I did mention, up until the point of disposal. The second thing is that they have to improve resilience. So hospitals have to be the last building standing. We do have climate impacts where we have extreme floodings. We don't want backup power of hospitals to be at the basement. We want them to start thinking of different ways of building facilities. We also want hospitals and healthcare leaders to take leadership responsibilities and begin to kind of use their political and economic influence to move and drive policy forward. We want healthcare leaders to basically support communities that are affected by environmental pollution, that are affected by different kinds of environmental disruptions. We want health leaders to begin to take cognizance of the fact that um, environmental burden of disease contributes 25% of the global burden of disease. And it is very important for us to start to recognize that prevention is better than actually, treatment, focusing our attention on treatment. So we want that kind of leadership responsibilities from hospital and healthcare leaders. To become a member, it's quite easy. We have a template online. You could just download the template and sign up your hospital or health institution. The tools and resources are also available online. and we're looking forward to getting you, started on the GGHH program. So with this, I would like to introduce the speakers. And as I mentioned before, um, we've worked with some of them in the past, and we're still working with some of them as well. Dr. Richard Amfu, Ms. Rudo Samudzi, and Mr. Makaton Lapo are all here to join us. And I'll just give a brief biography um, to introduce them. So Dr. Richard is a senior lecturer at the Presbyterian University College in Ghana. He has over 10 years of experience lecturing and 12 years of experience working on water, sanitation, and hygiene, where he has focused specifically on waste management, risk assessment, and water quality. Dr. Richard has recently been consulting for the UNDP Medical Waste Project, assisting hospitals in Ghana to phase out medical waste incinerators and introduce medical autoclaves, which are more sustainable. I worked with Dr. Richard on this implementation of this project in Ghana and in 4 other African countries in the continent. And it has been really, really successful. For Ms. Budo Samudzi, Udo is an assistant director for research policy and capacity building in Directorate for Healthcare Waste, Occupational Hygiene Risk Management. She's a trained medical scientist, medical biological scientist involved in a variety of research projects and standard operating procedure. She also manages healthcare waste database for Gauteng province, which assists with planning, budgeting, policy development, and high-level decision-making. She completed a master's degree in medical biology and also has a master's in business administration. She has a few publications in international peer-reviewed journals. Her passion for research has earned her the opportunity to collaborate with a variety of stakeholders to establish a comprehensive protocol for waste management of COVID-19 in Gauteng province. And she'll be sharing with us some of those strategies that she has used to develop the protocol. Ms. Dima Ntlapo. Dima Katso is a lead person for integrated waste management in Netcare. She's a qualified environmental practitioner by profession with extensive experience and knowledge in the field of environmental health. Ms. Ntlapo was employed as a chief environmental health practitioner for Betacloa Hospital before she joined Netcare as a lead for integrated waste management. She has a health, and environment management training certificate, and she's also a registered assessor and moderator with the Health and Welfare Sector Education and Training Authority in South Africa. So thank you very much, our guest speakers. I'm looking forward to your presentation. And with this, I would like to hand over to Dr. Richard Amfu.
Thank you, Lukman, for the introduction. And I want to welcome colleagues to this presentation. Thank you very much. So I'm talking about beating COVID-19 pandemic, the role of healthcare waste management in this era where the whole world is facing this particular pandemic. Lukman, can you start with the presentation slides?
Yeah.
Thank you. So that is the brief outline. I will talk about the introduction, cases, interventions that have been put up to deal with the cases, healthcare waste management situation. We'll look at the transmission and the arguments. We're looking forward to is the fact that the healthcare waste could also be an important avenue for the transmission, since not much is known about it. Then we'll look at the effect of ignoring it and actions that we can take to beat the pandemic. So can we start? Now, globally, we know that Wuhan was the first to report the COVID-19 case in China. And in December last year, 2019, the disease has wage war against countries, and globally, the confirmed cases has hit over 4 million, and we have a number of deaths recorded, high number of deaths recorded. And this has actually stretched it. And so the resilience of healthcare or hospitals have been challenged by this pandemic. It's not the climate change, but the pandemic that came in December, that is the COVID, and we are still battling with. And this is still affecting businesses and government. Many people have lost their job. Other people have had their pays being cut off and all that. Governments have had their budget plans thrown overboard because they have to now plan for this emergency, which wasn't catered for in their budget. Philanthropists and other non-governmental organizations have all the fight because they have to now put aside their own original plans and programs for the year. And so we see that the pandemic is stretching globally every entity. Now, as part of actions to reduce the spread of this infection, various actions have been taken, including development of protocols and strategies in order to halt the spread of the infection among the populace and then within the working force. Currently, you can see that Africa also has not been left out of this pandemic. The WHO has predicted that will be the next epicenter, and we recorded our first case in 25th of February. But since then, the disease is spreading all over the continent, and we have currently about 60,000 confirmed cases with over 2,000 deaths and some reported recoveries. We know that South Africa is the leading, and they have hit about 11,000 now. Ghana, we also recorded our first case in March, around 17th, 18th March. We recorded our first cases, 2 cases, and since then the country has has not stopped because the rate is increasing. We currently have about 5,127 cases with 22 deaths and about 494 recoveries. That is the current update, indicating that the disease is continuing spreading within the communities and people are getting the infection. In spite of this, some to halt the spread and to support the vulnerable, and that is to mitigate the impact the disease is having on people and to halt the spread, including the normal protocol of wearing face masks, which has become fashion sort of, and people are mandatorily required to put on face masks when going out. Yes, we are supposed to stay at home if we don't have any important business doing in town, but people are still going to town, and so you have to put on face masks. Government has absorbed water bills for the month of April, May, June, and then also 50% of our electricity bills. We have all our borders closed, schools closed, churches closed, which is not unique to Ghana, but a number of African countries have all these measures in place. There are incentive packages that have been instituted for frontline workers, including to support the frontline workers. Though there's a debate about who is a frontline worker, that has not been properly conceptualized because there are people who are also equally endangered because of the line of work they do in the healthcare system. Now, there are financial support that have been devoted for small scale and micro enterprises to bring them back to line so that after the COVID, we can still have business running. So our president is popularly quoted that we know how to bring back our economy, but we don't know how to bring life back. And so that is driving the agenda for beating COVID in Ghana. Zoom Park is one of the private healthcare waste management institutions, and currently in Accra, they are taking most waste from the case management centers. Most of the case management centers they are handling the healthcare waste for treatment. There are some of the facilities that have treatment facilities to deal with the infectious waste. In Ghana, the hand washing has now become popular, and we have Veronica buckets, which is a bucket with tap that runs by turning it. People have invented ones with solar systems to operate automatically. Others have ones that with you use your leg to press for the water to flow for you to wash your hand. And so all these are some interventions and inventions that have come up as a result of the COVID-19. Now we have some challenges because it is behavior that is determining whether the disease will spread or not. If the healthcare system is going to be more challenged, it depends on the behavior of the people. And so some people are refusing to use the nose masks and then staying at home, washing their hands and social distancing. Even in this COVID, people are organizing weddings. These are challenges that is contributing to the spread of the infection. Notwithstanding, in the healthcare system, we have healthcare waste management challenges that need to be addressed within the health facilities itself and areas where COVID cases are being managed. Remember, most of the items that are being used currently for in the COVID cases are single-use items. And the implication is that we have huge volumes of waste and infectious waste being produced, which may go beyond the 15% that WHO has already put forward as the infectious waste of the waste from health facilities. And so the COVID has actually brought high volumes of healthcare waste that require proper attention and treatment. Can we go to the next slide? And so we have problem in our part of the world, especially the developing countries. Most facilities do not properly segregate waste, infectious waste from the general waste. And so you have situations where waste are mixed and they are normally dumped at communal dumping sites. And once they are mixed, no treatment whatsoever is offered. And some treatment technologies that are also employed are not environmentally sound and friendly, and therefore contribute to other disease conditions among populace. Now, we have limited logistics and resources for managing healthcare waste in some of the facilities. You may only see a sharp box with a general waste container, which takes both infectious and non-infectious waste. We also have people talking about unavailability of PPEs to be able to handle the waste properly. And so we think that staff from these health facilities may even be exposed. And this is the situation with the healthcare waste that we need to deal with. So it's require proper management, a proper planning and strategy to be able to improve that. That is why the Global Alliance for Waste Pickers also has come up with their recommendation for waste pickers at the end of the waste management value to be protected as they go on contributing to sound waste management and resource recovery from waste. Can we move on to the next? Now, popular transmission route for COVID-19 as put forward by the WHO is person to person, and air droplets is known, but we also know that surfaces of objects can hold the virus for different time schedule, and plastics, which is one of the most commonly used items, single-use item in the health sector, can hold the virus for about 3 days, 72 hours, meaning that if you are one managing waste from healthcare facilities, plastics from these facilities could harbor the virus and can serve as a route for transmitting the disease. And therefore, healthcare waste workers and people handling healthcare waste are susceptible to this virus infection and can contribute to the spread within communities. And when we have waste pickers, then they can also pick the virus from the work they do. And once that happens, then the effect will be manifesting. And therefore, if we don't pay proper attention to healthcare waste management in the facilities where cases are being managed, then beating COVID-19 will just be an illusion. We will still have a long way to contend with, because then the waste management will create a vicious circle situation where the treated patients can be reinfected and other people can be infected through poor management of the healthcare waste system. Please, can we go to the next slide? And so, yes, I have thought about a vicious cycle, and it will mean that we have we will have increased cases of COVID-19 among waste handlers and the pickers, and the incidence of COVID-19 on the continent and in the countries in Africa may increase, and this will disrupt the normal health system and therefore will continue disrupting life activities of all of us, because currently some people don't feel safe to go to health facilities for service because of COVID-19. And so they say, if you are sick, stay at home, call your doctor, and be sure before you can go to the health facility. It means that all those places have become risk environment that can spread the infection. Now, if we continue this way, also the treatment system we use could contribute to pollution, and then we can have indiscriminate waste disposal, especially the infectious waste can be disposed of at communal dumping sites without treatment, and that will create a bad situation for us. Let's go to the next. And therefore, we need to take action to be able to halt the spread of the disease. And some of the action, including developing and implementing healthcare waste management strategy to beat COVID-19. And I'm happy that Rudo will present on the strategy she has developed for their facility to be able to beat the pandemic. And it's important, once you develop it, you also have to put in place logistics for implementing it. And then we provide add resources and logistics for the people who are working with the healthcare waste system and all the workers in the health facility, especially the consumables, the waste liners, the hand gloves and the nose masks and all that, and the aprons. We have to provide them. Avoid mixing of infectious waste with the general waste. So all efforts must be directed at improving the segregation. And so protocols that have been developed for this segregation should be followed by health practitioners, especially the nurses and the doctors handling the patients. And then those who are handling the collection should not break the chain of segregation during the collection process. Treatment of healthcare waste now becomes very important, either on-site or off-site. We need to pay attention to that and treat it so that it will be safe to kill all the pathogens, so that the infection will not continue in our community. The treatment technology we select should be efficient in terms of energy, in terms of the ability to treat, and it should be environmentally friendly. So that is very important for ensuring that the treatment technology do not pollute the environment. Then disposal at approved facilities. So we're saying that if we don't manage the healthcare waste system well, it can contribute to environmental pollution, and that will result from in-case management facilities. And in some cases, we may have open burning of waste, and some may also use incinerators that are not environmentally friendly and could also pollute the environment. And therefore, we need to take action. Some of the steps we can take to beat the pandemic are as follows: developing and implementing healthcare waste management strategy. Yes, this is an emergency situation, and therefore we need to have a strategy to handle the waste. But we need to have a comprehensive strategy. We should all encourage them to avoid mixing waste. Even the waste collectors at the health facilities, the orderlies or the cleaners, should avoid mixing the waste, infectious waste, with the general waste. Then we need to properly treat the healthcare waste, infectious waste, before disposal. And we can use the on-site system or off-site system. Should be efficient in ensuring that they are dead before the waste is taken to the disposal facility. And then also it should be environmentally friendly. If it is incinerator, it should be a double chamber that can burn over at a temperature of 850 degrees Celsius and above. And then we can have non-incineration options like autoclave, hydroclave, other options that are available could be used. Then disposal at approved facilities. We want to avoid indiscriminate disposal of infectious waste at places, and therefore we have to have designated areas being used for disposal of infectious waste from the health facilities where cases are being managed. Then we need to also develop and implement housekeeping protocol. So we should have frequency of cleaning our doors, our floors, and surfaces, because the virus can stay at these surfaces. And then tools and chemicals that we use should be environmentally friendly. And we also have to look at the procedure for safety measures that have been put in place at the facilities. Then capacity building for waste pickers and all waste handlers. We need to build their capacity. Even the clinical staff need capacity building for ensuring proper segregation. We need to create awareness among the healthcare workers, the frontliners, and the general community, so that we will avoid the risk of getting into contact with these infectious waste, if especially they are not treated. Then there should be monitoring of all the interventions that have been put in place, and then we look at where we can make corrections and then adapt to a new practice that will improve the system in our health facilities. So when we take these steps, I'm sure we can reduce infection of the COVID-19 through the management of our healthcare waste. Next slide. So on that note, I want to thank you for your attention. I want to acknowledge my university for the opportunity, as well as the CEO of Mondan that contacted me for us to write this article. And so I'm grateful. They have a blog and they asked me to give them an article for their blog. I'm grateful to them also for the opportunity. Lukman and GGHH, I want to thank you also for the opportunity for the presentation. Thank you very much.
Thank you, Dr. Amfu. I think you've raised some very important points there. I think it's really important that you emphasize the need for training and retraining. I think that is really, really important, that we do not go back to the old ways of doing things. We need to keep on kind of re-emphasizing the need for people to practice proper segregation at the source, and disposal. Rudo?
Hi, good morning. Thank you, Lukman, for the introduction, and thank you also to all the listeners. Thanks for this opportunity to present our isolation waste protocol for the management of COVID-19 medical waste. Next slide, please. So when you look at COVID-19 in terms of disease classification, we've classified this as a class 1 or a category 1 or category A notifiable disease. And diseases in this class obviously need to be reported to the public health authorities because they are infectious, because they do cause deaths. And some of the characteristics of your class A viruses is that there's an unexpected pattern of cases that occur. You get suspected cases that possibly lead to deaths. The increased incidence of disease also causes a major public health concern. It causes social discomfort, which is exactly what's happening with the COVID-19 pandemic. There's also a potential for such diseases to lead to outbreaks, which are obviously in smaller communities, which can spread on an epidemic level, and then which can also spread pandemically. And this may indicate that there is a newly recognized agent that has actually reached us. And also, in some cases, these agents can be seen as an act of bioterrorism. But in the case of COVID-19, we do not believe that this virus was created to kill off people, which is some of the speculations that happened when the outbreak occurred. If you see the picture at the bottom, it actually depicts what scientists have been doing in the background. They've done some lab tests to actually look at the DNA profile of COVID-19 and found that it was just above 95% similar to a virus that was isolated in bats. So they believe this virus came from bats originally and that it may have mutated to infect another animal, such as a pangolin or a fish or a snake, and then may have mutated again to infect humans. Next slide. Okay, so if you look at this slide, it just basically gives you a list of some of the diseases that are also classified as a category 1 or a class A. I've highlighted some of them because those are the ones that I just wanted to touch on. You know, when we did our consultation initially, you know, when the pandemic started, we weren't sure how to class this virus. So we actually consulted with a number of professors, and they said, since we don't know how this disease is actually going to progress, we need to treat it almost the same as influenza A, which has also been classified as a class A virus. If you look at, there's MERS and there's SARS. Remember the SARS outbreak that happened in 2002 and the MERS that happened in 2012. And these are also coronaviruses, which have now obviously evolved to what we have now as COVID-19. Then we also have our viral hemorrhagic fever, or our VHFs. Everybody knows Ebola as one of the very devastating epidemics that's also hit, has also hit certain parts of the world. And coincidentally, before you know, the pandemic hit us, we were finalizing a VHF SOP for the management of viral hemorrhagic fevers, should that, you know, hit our country. So a lot of the procedures from our VHF have been sort of adapted and modified to suit a guideline for the management of COVID-19 waste. And also in some of the classification strategies, you'll also see that they talk about respiratory diseases caused by a novel respiratory pathogen, also as a class A. And this is where COVID-19 fits. And patients who have these diseases are usually isolated. So subsequently, we will also treat the medical waste that comes from these patients as isolation waste. Next slide. So this is just a graph that was put together by one of the doctors who was still sort of assessing what this pandemic could be like. If you see on the y-axis, you will see that that represents the spread. So you've got from low, medium to high spread of the virus. And then if you look on the x-axis, you will see that represents the lethality. How lethal, how deadly are these diseases? If you look at Ebola, obviously everybody knows Ebola is highly lethal, but the virus doesn't spread as much as some of the other ones. So there is low spread and high lethality seen with Ebola. With your Spanish flu, you've seen that that one was quite a killer back in 1918. Very, very lethal. It also spread a little bit more significantly than something like Ebola. And then you have your H1N1. H1N1 started to scare, to scare, but then what happened was we found that it didn't really transmit very, very highly, and it also didn't become as lethal as people may have expected. And then you have chickenpox. Everybody knows that that virus spreads very quickly, but it's not very lethal. And then what's interesting is that you've got your measles, polio, and your smallpox. And those viruses spread very quickly, and they were very, very lethal. What's nice now is that there were obviously vaccines now developed for those, and we've got smallpox, which is also eradicated. And you know, the doctor believes that COVID-19 is sitting somewhere there in the middle, which is not a very good place for it to be sitting, because it's sitting that it's spreading quite significantly and it's also killing quite significantly. And obviously the perspective will be different for different countries, but we hope that it does not go the direction of your polio, measles, and smallpox, even the direction of Ebola, because we also don't want it to be as deadly as that virus. We hope to bring it down to where your H1N1 is, and even lower, because we have seen that COVID is much more infective than your normal flu. So we need to take extra precautionary measures. We need to do and put in all the efforts that we can to fight this virus from continuing to spread and continuing to kill. Next slide, please. So when COVID began in South Africa, Gauteng province was actually at the epicenter of the cases. And if you can see from this bar chart here, that just shows the pattern of COVID-19 cases that happened in South Africa. Our first case was on the 5th of March, 2020. And as you can see, the cases or the daily positive cases that were reported were rising. up until we went on lockdown on the 27th of March. Then we saw a significant decrease in the number of cases. But since then, our cases have risen because that was also still early days, and we are only now getting into our winter months. So, as Dr. Richard mentioned, the cases are being updated, and as of today, we are actually at more than 11,000 cases. We are at over 200 deaths, and we've got recoveries of about just over 4,000. Our death rate is sitting sort of at about 1.9%, which is within the range of the death rate of COVID, which is between 1 and 3.4%. And our recoveries are about at 41%. So it actually takes quite a while to recover from COVID. And that's why we're probably seeing the rate of recovery not as high, because our deaths are not very high, but we're also seeing that there's an excess of 5,000 people who still haven't recovered, who are still sick. And we find that in people with mild symptoms, they may be sick for about 1 to 3 weeks, and then those with severe symptoms can be sick for up to 6 weeks or even longer. Right. Okay, a breakdown of the cases. This was what the update on the 10th of May. But now, the latest update is that we're actually seeing over 6,000 cases for the Western Cape. Gauteng has reached now over 2,000. KZN is still sitting at about 1.3, with the Eastern Cape at 1.2 cases. The Free State is actually doing quite well and has managed to keep its cases sort of at bay, and the other provinces also don't have a lot of cases. What's interesting, as I mentioned earlier, is that Gauteng was at the epicenter, and now we are seeing almost triple the number of cases in the Western Cape. And there's speculation as to possibly why these cases have risen. Now we are at level 4 of our lockdown, so there is a little bit more activity. Factories and supermarkets could also be a source of some of these cases. There's also been some inter-provincial travel. So there's been travel between the Eastern and the Western Cape. So you've got positive cases that are traveling between provinces and possibly reasons for infection. What we also noticed is that in the beginning of the pandemic, screening was done mainly on symptomatic people. And the challenge there is that COVID-19, you can pass the virus on even when you are not symptomatic. So I think it's important, and I think our governments are aware that now screening needs to be done among all people. Anybody who is not showing symptoms, or whether you are showing symptoms, needs to be screened for that reason to assist in actually identifying active cases. Okay. Interestingly enough, Dr. Richard also mentioned the surfaces, how long coronaviruses last on surfaces. And there's some articles that were published as well in light of that looked at how persistent coronavirus was on inanimate objects. What's interesting is that information is constantly being updated. So in this article, they actually showed that coronavirus can remain infected for up to 9 days. Similar results have been seen for your COVID-19, and it has been shown that surfaces in healthcare facilities are a source of viral transmission. If you look there, you can see glass coronaviruses can last for up to 5 days, up to 5 days as well on your ceramics, 4 days on your wood, on metal 5 days, paper up to 9 days, and plastics as well is about 4 to 5 days. Surgical gloves is very important, lasts for up to 8 hours. And then on your disposable gowns, it lasts for up to 2 days. So I think it's very important to take this seriously and to be aware. And that's why we have to take extra precautionary measures in our healthcare facilities, because this virus can last on these surfaces at room temperature, which is between 20 to 25 degrees Celsius. Obviously, at higher temperatures, the virus cannot survive. So now if we look at our waste management guideline for the province, it basically covers procedures for the following. We look at procedures for facilities with compliant isolation wards. So that means they'll have the anti-room, which is the clean room, where the exchange between waste can be done. We look at facilities that don't have compliant isolation wards, and that's actually most of our facilities. We only have 2 hospitals in the province that have compliant isolation wards. We look at the disposal procedures for clinics, for emergency medical services, for our forensic pathology services, for our quarantine testing sites, and also for home isolation. Slide. So I'm just going to look at the key procedures and not go into detail about all the different facilities, but basically our principles for management of COVID-19 waste in Gauteng hospitals is as follows. Each hospital was asked to identify a room or a ward where they could isolate suspected or confirmed COVID-19 patients. Obviously, one room per patient because those patients need to be isolated. Now, in the ward, they have to prepare consumables. So if you can see there, your sharps containers, anatomical containers, pharmaceuticals, if any pharmaceutical waste will be generated. And then a freestanding rack also needs to be made available, or a trolley. On this freestanding rack or trolley, they will be placing red liners and they will double line the freestanding rack. And this is also to ensure that the double bagging principle of isolation waste is followed. So once that happens is any sharps that are generated will be disposed in the sharps container, respectively your anatomical waste in the containers and your pharmaceutical waste. And then once those containers are full enough, they will be sealed and they will just be disposed in that double bagged liner which is sitting on the freestanding rack. We use small containers because we don't usually generate a lot of that waste. So those containers will be big enough to fit into probably an 85-liter red liner. Once all that waste has been disposed, that also includes PPE. That also includes any food waste from the patient because we're recommending that disposable cups, plates, cutlery, and etc. are used for the patients. Those will all be disposed in that red liner. Those red liners then will be sealed because remember now it's double lined, so there's the double bagging. Once it's full enough, it will be sealed with biohazard tape and then it will be disposed into a box, either a 50-liter or a 140-liter box, and that obviously depends on the facility. That box will be sealed and then it will be taken into storage, temporary storage. Next slide. So there is no distinction between a COVID positive and a COVID negative patient. So once those boxes are sealed and sent for storage, it will be written COVID-19 or coronavirus on the box. The reason we are not distinguishing between positive and negative patients is because the test results sometimes take too long to come back. So you sometimes could sit for a week not knowing whether this patient is positive or negative, and then the medical waste will still remain and it needs to be collected very regularly. So we said in light of that, we will just say if this person is a suspect, we will write COVID-19 on the box. Also important is that the containers, each of the containers has barcodes, the sharps, the anatomical, and the pharmaceutical. And what we recommended is that the last 4 digits of those barcodes also be written on the box. And this is just to ensure that should anything happen during the while the waste is being transported to the treatment facility, at least the contents of the box is known. Also, if there are any pressurized containers that have been used and that have been disposed in the box, that should also be labeled on the box. Now, we've asked facilities to identify an alternative storage area, so they could use a sluice room or another room in the hospital, preferably close to where they're isolating the patient, that they can place these boxes, and they can only place those boxes for COVID-19. So that waste must not be mixed with other healthcare risk waste as well. Okay. A separate vehicle will also be provided for the collection of COVID-19 waste only, and that is for the service provider. So the service provider will come in a vehicle dedicated for COVID-19 and may go to other hospitals also to collect COVID-19 isolation waste. And we initially in our VHF protocols requested that the Metro Police escort the service provider to the treatment facility. But because we have so many cases, so many hospitals, we said that that would not be feasible. COVID-19 spreads much more quickly, and most of our hospitals are also burdened with the patients. So when the service provider comes to collect the boxes, which are now stored in temporary storage, they will come with a mattress liner, and they will collect those boxes from the storage area. There'll be a handover either from the sluice room or the room that has been identified. About 4 50-liter cardboard boxes can fit in a 650-liter mattress liner, and probably about 2 to 3 of the 140-liter boxes can fit. Service provider will obviously come dressed in their PPE. They will seal those boxes in the mattress liner and take them to their vehicle, which will be loaded to take for incineration. So in terms of the collections, what we recommended is that service provider comes every 48 hours to do the collection. Initially, we had wanted to recommend 24 hours, but obviously because our service providers are also burdened at the moment and we've got a lot of hospitals that require collection, we relaxed the standards. Alternatively, if a facility has also made arrangements that collection can happen maybe twice a week, that is also fine, as long as that waste is secured and there is no unauthorized access to the rooms where the COVID-19 waste is being kept. So for the procedure for the clinics, quarantine testing sites, and the EMS, basically the principles remain that there should be double bagging. So at the clinics or at the quarantine sites, what's happening is that boxes are placed outside the quarantine sites where people under investigation can dispose their food waste and everything. Boxes are double lined, either 50-liter or 140-liter boxes. There are no freestanding racks or trolleys available, mainly at the quarantine and testing sites. So all the waste is disposed into the double lined box. The double lined, the liners are sealed, the box is sealed similarly, and they are also placed for storage as within the hospitals. PPE as well, also disposed in the cardboard boxes, and they must be stored. Service provider must obviously be notified of the generation of that waste. Next slide. So some of the challenges that we've picked up, and our protocol is now on draft 4, because at draft 1 it was still in its infancy. There were a lot of things that we hadn't taken into consideration, and we got all our new procedures or our new recommendations based on the challenges and the queries that came from our hospitals. So infrastructure was one of the big challenges, because you would find a situation where rooms are too small, they don't have areas to store the waste, or there's not enough space. And we asked facilities that, based on our recommendations for the guideline, they also should write their own SOPs to suit also the infrastructure of their facilities, just not losing the essence of the double bagging, placing them in boxes, storing them separately from other healthcare risk waste. Okay, some of the challenges also, insufficient PPE. That's one of the biggest challenges that we're also having. Not enough resources. So much PPE is used, and our healthcare system is currently struggling with that at the moment. And then there were issues also of role clarity. So, what we had recommended initially is that our IPC, our infection prevention control staff, are the ones that handle the medical waste from COVID-19 patients. Because it's highly infectious, they are highly trained. But what we found is that we are also under-resourced in terms of our staff complement. Our nurses are overworked, and they actually mentioned that they need assistance. So we said that our cleaners or general assistants can also assist in managing COVID-19 isolation waste, provided that they are well trained and provided that they are also given PPE. Same with our waste collectors as well. They were also given training, provided with PPE, and also educated about COVID waste and about the risks and everything relating to it. Future plans, well, some of these plans are sort of already happening at the moment. Building of hospitals, there is currently a hospital that is being built. It's about over 400 bed hospital that's supposed to assist with isolating patients who are positive and also people who are under quarantine. So one of the recommendations I would actually make is also that each hospital actually gets built sort of an isolation ward. So that should something like this happen again, facilities are prepared, because this pandemic has actually shown that we are not as prepared as we may have thought we were. Also, reallocation of resources. Obviously, governments are injecting funds to support the fight for COVID. So that's something that is actively happening. Training and capacity building, that's something that is obviously ongoing, because we obviously need more environmental health practitioners, we need more nurses, we need more doctors on the field, and we just need more of our healthcare workers to be aware of what's happening, to understand the dynamics of COVID-19, but to also understand that as long as we are aware of what we are dealing with and we're provided with the proper resources, we will be able to fight COVID-19. It is a fight, We are still yet to see the peak in South Africa, which has been speculated to be around September. So as long as we stick together, we will be able to fight this. But obviously, we need to be well equipped. We need to be well aware. And we hope also to publish our draft protocol once we feel we have covered all the challenges and everything, and take it from there. And with that, I would really like to thank everybody for taking the time to listen, and also thank you for the support through this outbreak. Thank you very much.
Thank you, Rudo. That was a fascinating presentation. I think you kind of hit the nail on the head at the end, which was we need to kind of work together as a collective. I think one of the things that this virus has done to us is that it has shown us that together we can achieve a lot. So I don't want to take too much. I can already see that you have, Rudo, right now you have like 5 questions coming in for you. So I guess a lot of people really enjoyed your presentation. Thank you. With this, I'd like to hand over to Dimakato.
Good morning, colleagues. Once again, as I've been introduced by our host, Lickman, my name is Dimakato Nhlapo, the lead for integrated waste management from Netcare Limited. On behalf of Netcare Group, it is a great privilege to be given an opportunity to share our experiences with you colleagues pertaining to the management of COVID-19 waste. Firstly, let me give you an overview of who we are as Netcare Group. Lickman, you can proceed to the next slide. So Netcare Group, we are a leading private healthcare provider in South Africa. And as a leading private healthcare provider, we take full responsibility in ensuring that the waste that is generated in our facilities is treated in an environmentally friendly manner, and we prioritize environmental sustainability. Our core value is care. We care about the dignity of our patients and all members of the Netcare family. We care about the participation of our people and our partners in everything that we do. We care about the truth in all our actions. We engage everyone with empathy and respond with acts of compassion in all interactions with our patient and also our families. Our divisions, we have 54 Netcare hospitals, 79 Netcare 911 sites, 77 Medicross, 12 Akiso Clinic, National Renal Care, which is housed in our hospitals, and we also have Prime Care. So in a nutshell, this basically means that we are a major generator of both infectious and non-infectious waste. Before we proceed to the next slide, Lukman, I want to indicate Netcare has been in the spotlight in the past few weeks pertaining to our colleagues who were exposed to COVID-19 at our Netcare facility in St. Augustine. So basically, a total of 47 people were exposed, and none of them were waste handlers, fortunately. Two of the greatest challenges with COVID-19 is that those who are infected do not always have symptoms, and that is highly infectious, and that any building where people are brought together poses a potential risk of infection. So as Netcare, we had to implement additional measures at St. Augustine, and these measures include that the hospital emergency department had to be closed on the 2nd of April 2020, and the planned surgeries and admissions were cancelled till further notice. Deep cleaning commenced on the 2nd of April 2020, so we had to use ultraviolet disinfection robots. We had to use chlorine solutions to disinfect the area in order to eliminate the virus from infecting other people. Swab were also collected from staff members who work at the facility, patients who work at the facility patients that were admitted at St. Augustine as of the 1st of March 2020 were contacted, and this was to determine if the patients require any further investigation or testing. So also a dedicated 24-hour communication channel was set up. A 24-hour helpline was also set up. All screening and testing is being done in close consultation with the KZN Department of Health, and this is still continuing as we are about to open the hospital. PPE is still being provided on an ongoing basis, and over 16,000 healthcare workers have been trained on donning and doffing of PPE and also proper handling of waste management. So from this as Netcare, we have learned that COVID-19 is highly virulent and contagious, and moving forth, we are confident that given all of the measures and precautions that we have to continue to put in place, and we will cap the spread of COVID-19. So our deep and heartfelt thanks goes to all our healthcare workers and their families for their resilience and also the commitment that they have been showing. And then the good news is that on the 9th of May, KZN DOH advised that both the Netcare, KZN, St. Augustine and also Kingsway Hospital may be reopened. So both just that have been developed by the World Health Organization, the National Department of Health, the Center of Disease Control and Prevention, and also the Department of Environmental Affairs pertaining to how our waste should be treated. So the Department of Environmental Affairs issued a directive indicating that our service providers can either treat our COVID-19 waste with non-burn technology and also with incineration. So we currently have two service providers that are managing our waste. So our COVID waste is being treated with non-burned technology, and we're also using incineration. We are hoping that both our service providers will use the non-burn technology, but it seems that one service provider is still using incineration. So we have both accommodated those service providers and will continue to use that up until the department indicates that non-burn technology should be used for COVID-19 waste. We can move, Lukman. How is COVID-19 waste handled at Netcare? So basically for COVID waste, we only use sacrificial boxes. So the sacrificial boxes are placed in isolation rooms where positive patients and patients under investigation are admitted. Both general and infectious waste generated in the isolation unit are disposed in the sacrificial box set. So the box set is lined with a 100 micron red liner. We emphasize on using the 100 micron red liner because of its thickness and that no leaks can actually escape or that liner cannot tear. So once the box is 3/4 full, it is sealed with a biohazardous tape. And then using the buddy system or a second person technique, the person will stand outside of the isolation unit, and the person who's inside the isolation room will hand over the box to the person who is outside. The person who is outside will be holding double bags of the 100 micron red liner. So the bag will be placed inside those red liners, and then those red liners will be tied with a cable tie or the biohazardous tape, and then the COVID-19 sticker will be affixed on the red liner covering the box set. So that box set will be moved to the intermediate storage area where the the internal waste collector will come to collect the dead waste and then transport it to the central waste storage area. At the central waste storage areas, we have advised all colleagues in our facilities to ensure that they have a demarcated space where they specifically keep the COVID-19 waste to ensure that it is not mixed with other infectious waste streams. Also with the sharps containers, we make sure that once the sharps container leaves the isolation unit, double bagged and then transported to the central waste storage area. The colleagues at the facility level will communicate with the service provider to arrange collection. So a separate collection will be done for COVID-19 waste to ensure that it is not mixed with the other waste streams. And then a separate waste manifest document will be generated as the waste is being collected from the facility, and then it will be transported to the treatment plant. We have communicated with our service providers that the COVID-19 waste should be given first priority. So it should be treated immediately as it gets to the treatment plant. And then they need to send us the destruction certificate to ensure us that the waste has been treated in a safe manner. We can proceed to the next slide, Lukman. And also with the anatomical waste, we have indicated that in terms of placentas, our patients are not supposed to take the placenta home if the patient was a COVID positive patient. So we as the facility will take full responsibility to ensure that the placenta is safely disposed. And also with the pharmaceutical waste, we make sure that all the buckets are double bagged, and then the COVID-19 sticker is also affixed to the liner covering that container, and it's safely disposed. All right, and then how is COVID-19 handled? Oh, we are still there, sorry. And we can move back to that slide, Lukman. And also, as we are making our internal policies, we notice that we only focus on general waste and also medical waste, but we are leaving out scrap waste. So as Netcare, we went back to the drawing board and decided to develop guidelines that address how should scrap waste that is being removed from COVID-19 cubicles be handled. So working closely with infection control and also the technical service managers from our facilities, we decided that once the door handles or any other scrap waste is being removed from the COVID-19 unit, it needs to be zapped or disinfected and still be managed as scrap waste. We cannot put scrap waste in the infectious waste stream as it will increase our generation rates. So we zap it, we make sure that it's highly disinfected, and then we continue to dispose it as scrap waste. We can move to the next slide, Lukman. What has Netcare done to prevent COVID-19 exposure? Screening of waste handlers and other staff members. Screening is ongoing at all our facilities. We ensure that everyone who gets into our facilities is screened, and if the person shows any symptoms of COVID-19, the person is taken for further testing. Vaccination programs. We have vaccination programs at all our Netcare facilities. We ensure that waste handlers and all healthcare workers have access to hepatitis screening and also tetanus vaccines. We do risk assessment on a daily basis. We ensure that our risk assessments are updated. We also identify our facility areas as a green zone. So with a green zone, we know that is a low risk area. And then with a red zone, we know that people that work in the red zones may potentially be exposed to COVID-19. So we need to take extra measures to ensure that they are not exposed to COVID-19. And we also do compliance audit and also inspections on a daily basis to ensure that the waste that is generated in our facility is properly managed, is properly bagged, and then it is properly labeled and properly collected. And those that are coming to our facilities to remove that waste, they have proper PPE, and they also handle that waste with care before it can go to the treatment plants. Service provider weekly and monthly updates. So we communicate with our service providers on a daily basis to get updates on the collections that were being scheduled from our facilities, on the quantities that they have removed from our facilities, and also on non-compliance issues that they have noted so that we can be able to address them. And then with the statistics, the service providers give us that on a weekly basis. So we are able to monitor the trends if they are actually linked to the current cases that we currently have on site. Developing and implementation of policies and standard operating procedures. As I have indicated that as Netcare, we follow guidelines that have been developed and implemented by the National Department of Health. So we have done that, and we've also taken important points from the guidelines that were developed by WHO. So we've been able to implement that. Enhancing strong relations with the National Department of Health. So we continue to communicate with the Department of Health if we are uncertain or if we have challenges at our Netcare facilities. We continue to engage with the Department of Health. Training and health education. Training is ongoing. We arrange refresher trainings for our colleagues. We make sure that they get updates as they come from the WHO or from the National Department of Health. So we communicate via Skype meetings, we send out emails, we have WhatsApp groups. So we communicate with our colleagues and we make sure that everyone has information on COVID-19. We have COVID-19 emergency response teams, so our colleagues have access to the hotlines of who they need to communicate with whenever they encounter a certain challenge. And then we have daily meetings that happen on a daily basis where we communicate about challenges that we implement at facility levels, and then we also link our people at facility level with relevant people that they. So basically, this graph shows trends of what has been happening at Netcare. So basically, the waste trends are similar to the cases that are treated within our facilities. So we have seen an exponential increase in terms of our infectious waste and also our sharps. So currently, we are sitting at an additional of about 5,647 kgs of infectious waste that has been generated in our facilities as COVID waste has occurred, and most of the COVID-19 waste is being collected from our hospitals. Only 2 clinics so far have generated COVID-19 waste. The Port Elizabeth area is currently leading in terms of waste generation rates. So on a daily basis, they're sitting at around 2.3 kilograms of waste, of COVID-19 waste. So we can move to the next slide, Lukman. Okay, COVID-19 and recycling of non-infectious waste. So Netcare is in partnership with Adcott Ingram to recycle PVC waste to produce school. So based on the risk assessment into COVID-19, the board has decided to eliminate face masks and oxygen tubing from this initiative. So basically, we are collecting oxygen tubing, oxygen masks, and also the PVC bags from areas that are not used as isolation units. So basically, these PVC bags did not contain any body fluids or any blood, or they were not contaminated. So to manufacture school shoes and would donate them to schools. So since the COVID-19 has occurred, we've seen a decline in the volumes that we used to collect. So we have also decided to eliminate oxygen masks as they may potentially have body fluids that might still contain the COVID-19, and we also tried to eliminate these items because the patients that we're currently seeing are patients under investigation. So we're trying to curb the risk. So this will actually have an impact on the volumes that we would need to collect for recycling. So this is what we have done to ensure that those who are actually collecting these items for us do not get exposed to COVID-19. The recycling program is still continuing, but we have eliminated most of the items from being recycled. We can move, Lukman. Key lessons learned from the COVID-19 pandemic is that we need to have contingency plans in place in terms of managing waste during pandemics. Basically, we do not have those guidelines, and I think WHO or the National Department of Health need to prepare guidelines for such situations so that we can in future be prepared for other pandemics. Legislative compliance is vital. Collaboration between private and public healthcare is very important, and also continuous engagement with the government departments is very essential for us as the private healthcare sector. Treatment and transportation cost of COVID-19 waste will have an impact on the waste budget as cases continue to rise. There will be an exponential increase in the use of sacrificial boxes and red liners as we are double bagging the boxes and also sacrificial boxes for COVID-19 cases. So we are still going to use more box sets, and in terms of us still using incineration to treat this waste, will be polluting the environment more. So there will also, in terms of the non-burn technology, I think the Department of Environmental Affairs still need to look into eliminating the use of incineration plants for the treatment of COVID-19 if they want us to move towards the green approach. And then in terms of monitoring, monitoring of waste generation rate is very vital, and this can be used to set goals for minimization, recycling, and also reducing. So basically, these are the lessons that we have learned since COVID-19 has occurred. On behalf of Netcare, thank you very much for the opportunity that you have given us. If you have more questions, you can find us on the address that have been listed here so we can engage more colleagues. We continue to learn as this pandemic seems to be ongoing. So for us, it has been a learning curve, and the Department of Health has been very supportive and will continue to learn as we go. Thank you.
Thank you so much, Demakato. That was a very informative session. I think one of the things that we need to, and I think this is a question to the speakers, and I think it's really important that we emphasize that we already have. You talked about the guidelines, and I think Rudo also mentioned it. It's really important that we look at what the WHO has recommended for guideline for managing COVID-19 waste, and we should try and also recognize that there are some key elements to it. The waste from COVID-19 can be treated as any healthcare risk waste, basically, and there is absolutely no need for the double bagging, because I also saw that Rudo mentioned it as one of the requirements in terms of the protocol that you're developing. I hope that because it's not sustainable. It's basically not sustainable. You see that exponential increase that you did mention, Dima. We've seen that exponential increase in the amount of waste that is being generated, considering the fact that you cannot be able to establish if a patient is positive and or if a patient is negative. All that waste is all disposed of as COVID waste. So you're going to see this exponential increase in waste. So in terms of dealing with the actual waste from patients that are positive, there's absolutely no need to double bag. COVID-19 waste, according to WHO, is just like any other healthcare risk waste. If your protocols that you've already established are already in place to dispose of waste, there's absolutely no need to kind of, you just need to re-emphasize what you're already doing. There's absolutely no need to kind of add some more elements, which is understandable basically. But I think we are learning in this process. So I'm just going to, we're just over an hour now, and I think we should just address some questions that are coming in. So I'm just going to address this question to Dr. Amfu. Dr. Amfu, one of the questions that came in for you is with regards to medical waste incineration. I know that you and I worked on a project on phasing it out completely in 4 African countries, but you mentioned it as one of the treatment methods. What is the advantage? We don't really want to push medical waste incinerators, but we know that there are alternatives that are in place and that are doing a lot better, because medical waste incinerators contribute obviously to another situation of air pollution. But with the autoclaves that you've installed in Ghana, how has this helped with the treatment of COVID-19 waste? Dr. Amfu?
So yes, I mentioned incineration along the line because Stockholm Convention recommends incineration that are double chambered and that can incinerate the waste above the temperatures of 850 degrees Celsius, up to maybe say. In that case, you are sure of the fact that UPOPs or unintended persistent organic pollutant that could cause environmental pollution and health problems are eliminated from the process. But if we are going by our normal incineration process where we do it in barrels, then it is unsafe. That is why in my presentation I said double chamber incinerator. There are other requirements that Stockholm promotes in that regard. Now, in terms of our autoclaves, all our facilities where we installed, especially Cape Coast Teaching Hospital, is managing COVID cases, and so they are using the autoclave. Eastern region are also ready to use the autoclave once patients are sent there. We work with Ridge Hospital, they have autoclave, and so they are also using the autoclave for treatment. Currently, Zoom Park that we are partnering with on this project is a private sector waste treatment facility, and they have autoclaves, and they are managing case centers for one of the isolation areas, which has over 1,000 patients. And so they are handling the healthcare waste from there, and they are using the autoclaves for treatment. So in effect, it is helping. But the Kumasi Teaching Hospital, Konfanochi Teaching Hospital, we have incinerator that we work with them, and their incinerator conforms with Stockholm Convention's standards. And therefore, we emphasize also that we can use incinerators provided we can procure the ones that could not will not pose any environmental problems. And that is why I mentioned that. And it has some other advantage, some disadvantage, because it's very expensive to operate generators. And if you want to have a good one that is environmentally friendly, then you need to have a good financial base to be able to maintain and operate it well. But the autoclave is low in cost and also lower to operate and run it, and therefore it can easily be procured for this pandemic waste to be treated efficiently before disposal. It also enhances resource recovery if we want to recover resources from our waste.
Thank you, Dr. Amfo. I think what is really important, I think yes, you kind of hit the nail at the end, which is the advantage over medical waste incinerators. I think one of the major point I want to draw out is that, and I think we both saw this when we were implementing this project, is that the double chamber incinerator that you mentioned is not compatible in Africa. We know that, and that these incinerators require high maintenance and they are very, very expensive. We can't really we can't afford them basically, and it's high maintenance. It's not compliant basically, obviously, because it still releases a lot of pollutants in the atmosphere. And we know, based on experience, even in South Africa, we've seen that a lot of those medical waste incinerators are still not environmentally compliant. So I think we need to start thinking differently in terms of pushing for alternatives, because now with COVID-19, we are seeing that a lot of plastics are being used, disposable PPEs. All of these are all shipped towards, medical waste incinerators. And immediately you burn plastic, you get dioxins and furans in the atmosphere. So we need to start thinking differently, basically, which is what I really want to emphasize. Medical waste incinerators are that double chamber one is really high maintenance and very expensive for us to be able to maintain in this region. Okay, so the other question I have, I think I kind of mentioned it towards the end, is, so Rudo, this question is for you. With regards to the protocol that you are developing, I know it's still in draft form, but are there any opportunities for kind of improvement on it in terms of the double bagging, especially because we've seen, like you mentioned, there's a lot of now in that medical waste protocol in terms of what kind of waste goes inside, but if it's positive or negative from patients, alternative storage area. So the question that came up is, what was the idea behind all of those specific different additions that have been added to this protocol in terms of the storage area, the separate vehicle, double bagging of this particular. I know you mentioned as an isolation waste, but according to the WHO standard, it can be considered as a normal healthcare risk waste.
Thanks for the question. So I think because we are dealing with something that we don't know information about. We are still discovering about the COVID-19 pandemic. And I do appreciate WHO's recommendations, but I think it's also important to be sensitive to the end users and the workers on the ground. So the theory behind why we had our recommendations is also based on the extensive consultation that we have done. Before the development of our protocol, one of our hospitals was already adapting this procedure because they were the first hospital to deal with COVID-19 cases. They were not sure what they were dealing with, but all they knew that it was something big, it's something that's spreading, and it's something that's causing deaths. And at the moment, there is no treatment in the form of a vaccine for it. So unfortunately, media coverage has created a scare. So when we do our consultations, people are actually very scared to handle this medical waste that's coming from COVID suspects or COVID positive patients. So to also ease the psychological strain that's causing the pandemic is causing on them, we try to initiate extra precautions to make sure that they feel protected, so that they know that they are protected when they are handling the medical waste. Also, as I mentioned, we had just finished finalizing our VHF SOP, which obviously speaks to double bagging because of the lethality of your VHFs. So a lot of people adapted this protocol while waiting for something to come from Department of Health. And that's hence why we are also doing this, because people are looking at it that people are dying. We don't want, a situation whereby there's a case that happens as a result of either the medical waste procedures were not stringent enough. And we are willing to relax those standards once everything has calmed down. Remember, we're still going to reach the peak of cases with this pandemic, and we don't know what to expect. So we are rather taking extra precautionary measures, and then we can always relax the standards once things have started to calm down, either whether there's a vaccine available or cases have gone down and people are not as scared anymore. So, so that is the premise behind where everything is coming. Also, how we classified the virus also has steered us to how we are going to manage it and isolate it from other medical waste as such. I hope that answers the question.
Yeah, it does. To a large extent, I think we need to also recognize the fact that, as we move on, we need to kind of, readjust some of those stringent procedures that we do have. And so now it's in draft form, but is it going to be open for comments, should I say, or you're going to have it rolled out immediately?
Look, the drafts have been open for comment. They've been open for, and as I said, we adjusted our recommendations, obviously dependent on the challenges that facilities were raising.
Okay.
And
do you have any case currently of anyone who has contacted COVID from waste management?
At the moment, no, we haven't, and we hope it stays that way. And like I said, people are scared, and at the moment, some cases people don't even want to handle this. So when we do our training, we try and educate them enough about it and try and ensure that they feel protected so that they can actually work and manage it. Like I said, when things start to calm down, we are willing to relax our procedures. But in the meantime, I think there's more appreciation for us to be extra
Careful.
yes, until such a time that people feel psychologically relieved about COVID-19.
Okay. All right. Thanks, Rudo.
Okay.
I think there's another question here for Netke. I'll just take one more question for Dima, then we would kind of round this up because we're running out of time now. So Dima, the question for you here is speaking about how do you guys deal with your food waste specifically? So from patients that have come down with COVID and are being, fed obviously in hospitals, what happens to it? What happens to your food waste? Is it treated or is it disposed of in an infectious waste as well? Or how do you handle it?
Okay, thank you, Lukman. With the food waste that is generated from our isolation unit, we dispose it as infectious waste. So the food waste will go directly into the bagged box set, and then it will be disposed as infectious waste. So nothing goes to the general waste stream. We dispose it as infectious waste.
Okay. All right. I think this is my own question now. Just to summarize, I think and I would like each one of you to kind of throw in, one of the most important issues around communities. So Groundwork works with communities, and we have to recognize that to get out of this outbreak, to get out of this coronavirus outbreak, we can do as much as we can at the hospital level, but it all comes down to the strength at the community level. So when I say community, I mean your patients, I mean your community where these hospitals are being located. That's the most important point. Because we can do so much, we can create fantastic strategies and protocols. But the truth about it is that the spread of this virus is based, most of it is community based. So how do we control that spread at the community base? So as environmental health practitioners, as research people, as academicians also in the health sector, we need to build strong communities. And when we build strong communities, it means that people are able to take responsibility. People are able to take responsibility for their actions. People are able to, go out, wear a mask, move out without having to, you know, social distance, basically, without somebody having to stand and police you and chase you around. So it's about people taking responsibility, trying to protect not just themselves but everyone. So the question I have for you guys is, how are all of these strategies and techniques that you guys are employing at the hospital level, how is it translating down to the community level? So do you have a strategy in place that involves community as well as your staff? Because your staff is your community, your patients are your community, the people within the community where your hospital or your the province is, or the institution is, basically is your community. How are you guys? Is there any strategy? So I'll start with Dr. Amfu. What was the strategy in place in Ghana to reach out to communities and educate them to take responsibilities for their action, and also to build that strong community-based approach? Then then you can, Rudo, you take over. Okay, Dr. Amfu. Rudo, do you want to go?
All right. So at the moment, I think, still, we're still in the beginning phases, we're still learning, and there is a community screening that is taking place. I do believe that initially they were looking for symptomatic people. And I think that's why it may not have been as successful in detecting active cases. Because, as Dima also mentioned, COVID-19 can be transmitted by asymptomatic people. So if you're only looking for people showing symptoms, you might find that you actually get cases of people who just have a normal flu or, a normal cold, and it's not actually COVID. And I think what we need to do is we need to do screening of everybody. We need to treat everybody like they have it. And that way we will be able to detect more cases. We will be able to, understand also the pattern of infection that's taking place. So I think those are part of the initiatives moving forward, because I think especially with the Western Cape, where the numbers have peaked so much, they're going to instill more active screening where everybody is screened. I think to also contain this, it's also important to know where the hotspots are. So that needs obviously a little bit of more research. It needs more field work. And if you know that you can detect and identify the hotspots, then you'll be able to instill more stringent measures for quarantine, for restricting movement. I think restriction of movement is also very important, even now between provinces, because that's also a possible reason as to why we've had an increase in the number of cases. So those efforts, I think, will really assist. It's now, as we are reducing the levels, that we're probably going to see more infections. And I suppose the most effective measure would be to stay in quarantine and isolation. But obviously, understandably, because of the economic implications, we can't be on lockdown forever. So identifying hotspots as well, doing active screening of everybody, I think will sort of assist, and also educating the communities about the importance of following the recommendations made by our presidents, by our ministers, social distancing, hand washing, and all of those things will probably assist.
And while on that issue, I think just a quick question for you, Rudo. Somebody just asked now, in terms of, do you have a specific protocol with regards to waste from homes? Those who have who are actually in care at home and who are actually infected with the virus. Is there a strategy that the province has put in place to address the waste from those people?
Yeah, so that one was also quite an issue because it was a little bit of a difficult one to recommend. But what we had mentioned is that there've been community health workers who have actually been trained to go to the homes to do the screenings and the testing and everything. And what I understand is they come with your red liners. So any medical waste that's disposed from there is disposed in those liners. They take them back to the nearest clinic. There's also the option of people who are being isolated at home. Recommendations are that they isolate themselves in a separate room. I know sometimes that might not be possible, but where possible, if there's more than one room in the house, they need to isolate themselves in that room. They need to wear a mask. In terms of and now there was the issue with cloth masks versus surgical masks, because by implication, surgical masks are raw medical waste. So there was recommendations that people at home use the cloth masks as long as they're thick enough. I think it's about 3 layers. Those can obviously be washed and reused. Obviously, social distancing measures must be taken into place. People who are taking care of people at home must also wear masks. There must be frequent sanitizing and disinfection. People who are infected feel they can come in contact with surfaces. Those surfaces also need to be disinfected, with household bleach. And I think those procedures must be continuously followed. Somebody who is being isolated at home, if they are feeling seriously ill, they should actually be going to the hospital. I think it's probably those maybe who are not very symptomatic, who are being isolated at home, and that's why they should be wearing masks at all times.
Okay, thanks, Rudo. Dr. Amfu, do you want to go now?
Yes. So in Ghana, where we have a number of activities that are being carried out to involve the community. So we've already had disinfection activities at almost all the markets in our towns. And currently there's disinfection going on in second cycle institutions. Tertiary institutions have had disinfection. So these are activities that have been done to disinfect areas. Now, with the areas where case management have been taking places, also the disinfection activities have been done, and it is an ongoing activity. We have community-based information system, which are normally from the municipal assemblies, and they also educate community members about the COVID-19. You enter almost every 200 to 300 meters, you may see a standby hand washing facility with soap. Some of them have been mounted by churches, others by philanthropists, and others by government, local government authority. Shops, before you enter shops, you have to wear your nose mask. And so some shops, before you enter, you see a line mounted so that you don't pass the line. So you stand there and then you are served. We have also come out with guidelines for producing local masks. And so some sewing centers are producing locally made nose masks, which are double lined, and in some cases they are triply lined to ensure that it's able to ward off any infection from there. And so that is also ongoing. Then we have general mass media education going on through the radios and the television, and people talking about it. And creating awareness among the populace. So these are the things that are currently going on. For instance, on our part as UNDP project also, we are supporting ministry. From Friday, we are rolling out training sessions for frontline workers at all the, especially areas where we have higher cases. You know that we had a lockdown and we have lifted a lockdown. It was in major epicenters, Kumasi and Accra, but we have lifted. And so we're going to have education session for the front lines and doing monitoring of activities going on in the health sector with the Health Regulatory Authority from next week going. So some activities are currently going on to engage community members or to make community members aware of the pandemic. But the usual thing is that we have attitudinal challenge. Obviously, because of struggle for survival, as Rudo said, people are looking for economic strength to be able to live. So they are trying to balance the pandemic as against hunger so that we can find a middle way. So that is currently what is going on in the country.
Thank you, Dr. Amfo. Dima, do you want to go?
As NetCam, trying to reach out to the community, we've been screening and educating everyone who's entering our premises. So we ensure that we ask them questions about their travel history, whether they've been showing any symptoms that are related to COVID-19, and we also give them health education. We also engage with our local municipality environmental health practitioners if we suspect that they need to do tracking and tracing of certain patients that we have seen in our facilities. And we also have posters that indicate how COVID-19 spread, how should the waste be handled, and what other precautionary measures do patients or staff members need to take in order to protect themselves. We have WhatsApp platforms where we send out any updates that relate to COVID-19. We have internal postmasters where we send out information pertaining to COVID-19. We also prioritize the use of personal protective clothing, and we also emphasize on hand washing and also disinfecting of surfaces in order to eliminate COVID-19 germs that might be in those areas. And yeah, basically that's what we are doing. And we also encourage social distancing within our facilities. So we've been doing that as NetCare.
Yeah, thank you so much, Dima. This was very, very useful to know that you guys are actually, not just focusing on developing strategies for your staff or for the hospital, but also looking at how to reach out to communities, because I think that is really, really important. Dr. Amfu, one of the things that you mentioned was disinfectant spraying. This is something that we've seen across the globe now of people having to spray disinfectants at community, and also as a form of treating the waste even before it leaves the hospital. So there are different schools of thought around that. But at the same time, I think we should also be very mindful of what exactly we are introducing into the environment. We should also seek for some information with regards to that. WHO has released some documents with regards to disinfectant spraying. I think we should, all of these resource materials basically are all on our website. So I don't want to take too much of our time, but I just want to say thank you so much to all the presenters and to the attendees. I can see that we kind of reached a milestone. We have about 35 people from across the world, basically, not just Africa, who are listening in. So thank you so much for attending the webinar. I'm sorry I can't take all the questions because we're kind of running out of time, but we are going to move this conversation onto our Global Green and Healthy Hospital platform, Connect. So we're going to continue to have these conversations on Connect, and some of your questions will be addressed there. Dima, Dr. Richard, and Ms. Rudo all have Connect accounts, so I'm sure you'll be able to reach them. Means to be able to address some of the issues. and some of the slides. This webinar is recorded. We are going to share the recorded version with everyone who has participated, so you can also share it within your network. So thank you so much to the presenters, and thank you for the attendees as well. Thank you so much for supporting. So take care, goodbye, and I hope you did enjoy the webinar.